Hello, I'm Dr. Tanuja Chitnis. On behalf of CME Outfitters, I would like to welcome and thank you for joining us today at our educational activity titled Rethinking Routines in Multiple Sclerosis Management, What the Future Holds for DMTs and Cognitive Assessment Strategies. Today's activity is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians worldwide. Our program will be archived at cmeoutfitters.com. Today's CME CE activity is eligible for ABM mock points. Once you complete today's program, be sure to provide your ABM ID and birth date in the evaluation. CME Outfitters will submit your mock points therein. You can also claim this activity as CME for MIPS improvement activity. You can also follow CME Outfitters on Twitter and specifically the hashtag MSUpdate for upcoming CME CE opportunities and other news and resources related to multiple sclerosis. So once again, I'm Tanuja Chitnis, Professor of Neurology at Harvard Medical School, Director of the Partners Pediatric Multiple Sclerosis at the Massachusetts General Hospital, Director of the Translational Neuroimmunology Research Center, and Director of the Comprehensive Longitudinal Investigations of MS, which is the CLIMB study at the Partners or Brigham Multiple Sclerosis Center at the Brigham and Women's Hospital in Massachusetts. Let me introduce our faculty joining me today. I'd like to welcome my colleague, Dr. John Deluca, who is a Senior Vice President for Research at the Kessler Foundation in West Orange, New Jersey, and also Professor in the Departments of Physical Medicine and Rehabilitation and of Neurology and Neurosciences at Rutgers, New Jersey Medical School in Newark, New Jersey. Welcome, John.
Thank you, Tanuja. It's a pleasure to be here today with you. Thank you.
Thank you. I would also like to introduce my colleague, Dr. Lauren Krupp, Director of the Multiple Sclerosis Comprehensive Care Center at NYU Langone Medical Center and Professor of Neurology at NYU Grossman School of Medicine in New York. Welcome, Lauren.
Thank you. Hello, it's a real pleasure to be here today.
Wonderful. So I'd like to start by reviewing our learning objectives. Our first learning objective is to apply clinical data on the efficacy and safety of recently approved therapies to individualize treatment decisions for patients with MS. Our second learning objective is to incorporate cognitive assessment into routine monitoring for patients with MS. And our final learning objective is to evaluate emerging data on the effects of MS therapies on cognition. So let me start off by reminding our audience about the goals of treatment for both clinicians and patients. And so when I think about my MS patients, I really want to prevent several metrics. And one is to reduce relapses. The second metric that I want to really address is slowing disease progression. And then overall reducing disease burden. And these are what I would call traditional measures. There are also now evolving measures, and now that we have more information about MS and MS therapies and their efficacy, ideally it would be wonderful to end relapses, to stop disease progression, to stop MRI progression, and overall improve function and quality of life for our patients. So Lauren, I'm curious, you see a lot of MS patients, and we know that every MS patient is different. They have a different disease course, and there are some predictors of poor prognosis that I've noticed in my clinical practice, including older age. In some instances, there could be a more severe disease course. Men sometimes also have a more severe disease course, and as well, smoking has been associated with a more severe disease course, and that might affect some of my treatment choices. And Lauren, have you also noticed other clinical or radiologic features that help you to understand a patient's future prognosis?
Yeah, absolutely. I mean, one important thing always to remember is that most of this data is at the group level. So it's always a challenge with the individual in front of you to know if they're going to behave like the group. But nonetheless, that's the data we have. And I do rely on MRI quite a bit. So things like a large lesion burden, a large number of enhancing lesions, the presence of infratentorial lesions, spinal cord lesions, those are all factors on MRI that are worrisome in terms of prognosis. And more recently is the incorporation of brain volume into our assessment. So gray matter volume and whole brain volume are other factors that, make us more concerned about a more worrisome course. Certainly those patients with frequent relapses, poor recovery from the relapses, higher impairment levels at the time of diagnosis, and also the presence of cognitive difficulties right at the get-go. These are all factors that are worrisome for a more difficult prognosis. And then, on the biomarker side, aside from MRI, the presence of oligoclonal bands has been associated with more frequent relapses. And now the presence of measures like neurofilament in the CSF and even in the serum, as well as OCT, has been incorporated into ways of sort of trying to determine who's going to have a more problematic outcome.
I absolutely agree. And it's both, very informative and also important that we are now developing or have some prognostic tools to help guide our treatment decisions. And especially now that there are many new MS therapies that have evolved and have been introduced over the past 15 to 20 years. And, can you tell me your thoughts about the expanded treatment landscape and your views of how MS therapies have evolved?
I mean, the evolution is extraordinary, right? So I remember when we had no disease modifying therapies. So, the focus was always on symptomatic management. We now have a wide array of treatments with different mechanisms of action. Some are oral, some are injections, some are intravenous. They have varying frequencies. And, in general, I would say that the more recent years have been associated with developing therapies that are of higher efficacy, and also developing agents that are well tolerated and fewer side effects. So, a big challenge, of course, is, which of all these therapies to pick. And I think, incorporating the notion of what their mechanism of action is, what your feel for the prognosis of the patient is, are things that go into that decision.
Yeah, I agree with you, Lauren. Absolutely. It's both very exciting and promising that there are so many therapies to choose from, but also a little bit daunting. And, a way that I tend to categorize or think about therapies in my mind are in terms of their mechanism of action. And I think there are a group of therapies that I would term immunomodulators. And this could include the beta interferons, the glutaminyl acetates, the dimethyl fumarate types of drugs, and teriflunomide. And these have some benefits. Several of them have been around for a long time, and so we have long-term safety data. But then there's also the issue maybe of some more modest efficacy compared to some of the newer agents. Another category that I think about is the cell trafficking inhibitors, and this includes natalizumab, fingolimod, siponimod, and ozanimod. And again, I think this is exciting in terms of a new group or several types of medications that inhibit cell trafficking into the brain. And they have, in general, a bit greater efficacy than the prior class. But there is also a balance in terms of understanding long-term safety and potentially side effects such as infections. And then the third group, I sort of, when I'm talking to patients about therapies, I refer to are the cell depleting therapies. And these include alemtuzumab, cladribine, B-cell targeting therapies, including ocrelizumab, rituximab, and oportuzumab, and also now BMT, or bone marrow transplant, which is also known as autologous hematopoietic stem cell transplant. And these are quite effective, highly effective therapies, but again, there are some side effects that we have to watch out for. So I think it is a balance, and it's a decision to be made with each individual patient. What type of therapy would be best given their overall prognosis, their disease course to date, and then also, of course, their preferences for therapy. So I think it's also interesting to look at some of the new entrants into the MS space. And especially examining clinical efficacy and safety data that for therapies that have been recently approved by the FDA in the past year that our audience may be less familiar with. One of these is ofatumumab, and this was recently approved in the past year on the basis of large phase 3 trials, the Asclepios 1 and 2 trials. You can see here that there's a large number, almost 1,000 patients in each enrolled. And this demonstrated 97 and 93% reduction in gadolinium-enhancing lesions in the ofatumumab group compared to the teriflunomide group. And there was also a significant reduction in annualized relapse rate, 51 and 59% reduction in the ofatumumab group compared to teriflunomide. And overall, there was good safety and tolerability profiles and infection rates, which are similar to teriflunomide. So another new entrant is ozanimod, and this was approved by the FDA on the basis of 2 large phase 3 studies called Sunbeam and Radiance, again, over 1,000 patients enrolled in both. And this drug demonstrated a 63% and 53% reduction in gadolinium-enhancing lesions in the ozanimod group versus beta interferon 1A. As well, there was a reduction in annualized relapse rate of 48 and 38% in the ozanimod group compared to beta interferon 1A, and no clinically significant cardiac adverse events and lymphopenia or macular edema in the patients who received this drug, which is very, very positive and I think promising. So, these are our 2 new entrants. So, Lauren, we've talked a bit about different therapies and risk factors, and can you tell me how you think about individualizing therapies and selecting the best therapy for each patient?
Yeah, absolutely. I mean, the more you can, engage the patient, the better, because they're the one who's going to be taking this and hopefully compliant with it. So I break it into, the 3 main categories, which is, how active their disease is, the medication-related factors, and who they are and what their personality and comorbidities are. With respect to the disease activity, we talked a little bit about prognostic factors, whether their disease is active, whether they are evolving rapidly, severe. In terms of drug aspects, I break it up into, for me, a big issue is efficacy. Another one is tolerability. Another one is safety. And another is convenience. So, how well this is going to be incorporated into their lifestyle. And, the safety requires monitoring, and they have to be willing to undergo that. And then, of course, you have to be sensitive to drug-drug interactions. With respect to the individual, are they someone who can show up for appointments regularly? Will they have problems with the daily medication? Are they planning to get pregnant? In which case, you have to choose carefully concerning stopping a medication and not running into a rebound problem. And what will they be like with respect to adherence? So it's really it's critical that this is a shared decision to the extent that it can be. Not every single patient or family wants to take on that responsibility, but many do. And I think that that's where we need to go. I think the other thing is to be sensitive to the factors that the patients care about. They care a lot about not progressing. They care about serious adverse events. They care about having an improved quality of life. They're probably not as preoccupied as we are with MRI changes, but they do care about enhancing or preserving their functioning and their cognition. Those are all the different features that play into the process of choosing with the patient the right medication.
Lauren, I absolutely agree. And it is a complex discussion in many ways, but also guided in part by the physician. And of course, the patient or the person with MS is desires and goals. And I absolutely agree. Those are all important factors to take into account and introduce into the conversation. You know, another important type of treatment choice I've noticed, and there's been a lot of literature on treatment initiation choices in the past several years. And in practice, there are those physicians, there are some who are inducers, and they might start with a higher efficacy treatment or agent, and then monitor both for safety as well as for treatment response. And there's a thought that, you know, nipping it in the bud or controlling disease early is more beneficial in some cases. And then there are others who are escalators and may start with a first line or modest efficacy agent, which may have longer safety data, and then escalate up if there is breakthrough disease or suboptimal response. And so I think it's important to think about these two philosophies of treatment initiation choices. And I think there's not a one size fits all, but in some cases, induction may be more beneficial for an individual patient or escalation for others. And I think it's you know, another way that I frame the discussion of therapies with my patients.
Yeah, I totally agree. I mean, I have to confess, I'm probably more of a high intensity type as opposed to an escalation approach. And I share that with my patients. But the data that's out there, as I interpret it, to me suggests that high efficacy medications at the beginning leads to somewhat better prolonged outcomes with fewer people reaching sustained disability compared to an escalation approach. But you know, that's not high intensity or high efficacy at the beginning certainly isn't the right thing for everyone. And I think it's important to share with your patients where you're coming from. So, you know, I explain that I spend the day seeing the patients who are coming for frequent appointments because they're not doing well, you know, and so that certainly has an influence on my outlook, and that may not apply to them.
Yes, no, thank you, Lauren. I absolutely agree. I think these are all very important points. So I just wanted to briefly summarize. I think we've learned a lot in this first learning objective about the evolving landscape of MS treatments, two new entrants into the field, ofatumumab and ozanimod, and also the thought about individualizing patient therapies and really thinking about induction versus escalation, and also risk factors for a more severe disease course, and that might influence your choice of treatment. So let's now turn to our second learning objective, which is to incorporate cognitive assessment into routine monitoring for patients with MS. And John, I'll ask you, this is, you know, an area that you've been working on and studying for many years. And can you tell us a little bit about why cognitive assessment is so important in MS management?
Thank you, Tanuja. I think we all are familiar with the fact that cognitive problems that can have a significant impact on the everyday life of the patient and, of course, of the family. And these can be very widely distributed throughout the patient's life, affecting such things as employment. We know that up to 80% of persons with MS are unemployed 5 years post-diagnosis, which is a very significant impact on the patient and the family. But cognitive impairment is a large part of that. It also affects things as ability to drive an automobile. It affects social functioning, a variety of household activities, family activities, overall quality of life. And this is beyond simply the physical disabilities alone. So it can have a huge impact, and therefore its proper assessment is really critical, and its assessment early in the disease and throughout becomes critically important. When we think about cognitive impairment in MS, we know that MS is a heterogeneous disease, so there's going to be no really one size that fits every patient. But in general, if you're thinking about the types of cognitive impairment that one observes, the two biggest areas are clearly slowed information processing speed and efficiency of processing. And that's particularly important because that's usually the earliest sign that one sees in MS. But the other area that's significantly affected in persons with MS is learning and memory, and oftentimes is the primary complaint of the patient. And this can both of these obviously can impact everyday life activities. And an area that's really been understudied is executive functioning. Issues such as planning and organization and initiating activity has really been something we've been noticing to be much more involved in MS than the literature might suggest. And a lot of times executive dysfunction is difficult, of course, for patients to describe. So they'll oftentimes say that I'm having difficulty with my memory, or in fact, it could be more of an executive problem. Now, cognitive impairment, of course, is not equally distributed among all persons with MS. So even prior to formal diagnosis with CIS, approximately a third of individuals can show cognitive impairment. So obviously, cognitive impairment can be seen early in the disease. In relapsing remitting MS, roughly half of those subjects have some form and some degree of cognitive impairment. When you move on to the progressive forms of the disease, however, roughly 80 to 90% of those individuals can show cognitive impairment. And so this is very significant, again, given the facts of what it can have, the impact it can have on everyday life. Another factor that is associated with cognitive impairment is age. So even early on in the disease, in the teens and 20s, one can see roughly a third of individuals showing cognitive impairment. And as age increases, you can see that there's a progression in the cognitive impairment, the frequency and degree of cognitive impairment, such that above the age of 65, more than 90% of patients are showing cognitive impairment. And earlier there was the comment about how age is critically important. And you can see here, this becomes a significant factor. There's also the mention of smoking earlier. Smoking is also highly associated with cognitive impairment, as it is with other factors. So Lauren, perhaps you can talk about cognitive processing speed over time from pediatric to adult onset MS. Can you tell us about that?
Sure, John. So I see kids as well as adults with MS. And, there's a lot of concern about how kids are doing in school and what's going to happen to them in the future. And, the good news is that for the most part, most kids are doing pretty well on cognitive speed at the beginning. But compared to adults, what happens is over time, and it takes about 15 years, I would say, whereas, the adults will decline over time as well. The kids are a little bit more delayed in showing that decline, but by 15 to 20 years into the disease course, where the kids start out doing better than the adults at the baseline, over time, the kids, the pediatric onset group now as adults, say in their mid-30s, are doing worse than those adults who started out with an adult onset course. So, it's really an issue that I think has to be addressed. And I think it's another reason as to why we have to really treat early to control this outcome. But, John, aside from all the challenges that you were describing that are associated with cognitive impairment, what do we know about whether the presence of cognitive impairment has a predictive value in terms of this disease course of MS?
Yes, we do know quite a bit about that, Lauren, and you alluded to it earlier as well. We know that cognitive impairment early in the disease is a significant predictor of further decline. And we also know that gray matter volume loss early in the disease is also a significant predictor of cognitive decline. If you look at this slide here, we have some data which shows that thalamic volume at baseline can significantly predict cognitive deterioration. And striatal atrophy over a 6-year period is associated with cognitive decline. At baseline in this study, visual memory and verbal memory and information processing speed were significantly compromised, as well as verbal memory. But if you look at what happens at 6 years, there's a significant increase. Up to 50–60% of these individuals are showing increased cognitive impairment. Also, interestingly, from this study was that you look at fatigue levels did not change over that period, nor did depression. And so while we know that fatigue and depression can have an impact on cognition, it may not always do so. And the effect is really related to the neurodegeneration of use in terms of cognition. And if you further look at this kind of work, we have three different phenotypes at baseline. Those who are not showing cognitive impairment in the upper portion. And those individuals tended to not show much change over the 6-year period. But if you go down to the bottom where individuals had significantly and more distributed cognitive impairment at baseline, these were the individuals who were going to show significant change over the 6-year period. So these predictors are really important, and once again illustrates the importance of proper assessment, both looking at the cognitive decline, impact of everyday life, and radiological factors, particularly gray matter volume.
You know, I was wondering, Lauren, what means or what tools could you use for screening cognition in clinical practice? And how does your approach to cognitive assessment differ between newly diagnosed MS patients versus those who've had MS for a longer period of time?
So, it's a great question because assessing cognitive functioning is really can be challenging. Patients themselves tend to be not as reliable as you would think in terms of reporting or noticing this change. So there's the worried well who feel that they're declining, but actually when you do cognitive testing, do very well. And then there's the people with real cognitive impairments who are kind of unaware of it. So it's important to try to implement some screening. And one approach, of course, would be to send everybody for a comprehensive neuropsychological evaluation, but one that's not always available, two that can be expensive and time consuming. So another approach is to be more selective and use screening tools. So a number of different approaches have been advocated. The Brief International Cognitive Assessment for MS, or BICAMS, is a battery that was recently or in recent years developed and validated. And that contains 3 tests: the Symbol Digit Modality Test, which is a measure of processing speed; the California Verbal Learning Test, which is a test of verbal learning and memory; and the BVMTR, which is a test of visual learning or visual memory. Other approaches include a processing speed test or other computerized or computer administered assessments. And then there's the MAC-FIMS, which is a more detailed battery, similar to the brief repeatable battery, which are a series of neuropsych tests that take about 90 minutes to administer. I tend to use the single test approach, which is this Symbol Digit Modality Test. But there are challenges there because there's a certain amount of fluctuation, and you have to sort of put it in the context of what's going on with the patient.
Completely, I understand, and I think it's nice that there's several choices, but also very helpful to hear your thoughts on this.
Yeah, I think that with the SDMT, my approach there is to use it annually. And, if I see a clear, persistent change over time, that acts as a trigger to try to pursue in more detail with a fuller cognitive evaluation what's going on. One nice thing about the SDMT is that it correlates very well with brain volume loss, including cortical volume loss, the thalamic atrophy, whole brain atrophy. So it's very well substantiated. But I do notice that there's, patients have to be sort of attentive, ready to try their best, and, to get a valid performance result.
Well, thank you for that review of tools for assessing cognitive impairment. And Lauren, for MS patients who do have cognitive impairment, what options do we as clinicians have for managing this and understanding whether these approaches may be slowing its progression or perhaps restoring or improving cognitive functioning? Can you speak to that?
Yeah, I mean, there's a number of tools that are available online. We actually did a study looking at a cognitive training approach called BrainHQ, and found that in patients with MS, doing this computerized administered test at home every day led to better cognitive outcomes compared to things like crossword puzzles and things of that sort. And the real key is to make the test harder the better you do. So you really want to have people push themselves to the limit. And that adaptive approach is what I think makes the difference. But there are a lot more effective approaches as well that involve trained professionals to intervene. And I think John probably knows the most about this, and was wondering if you could tell us a bit about the benefits of cognitive rehab in MS and how you use that in your practice.
Yes, thank you, Lauren. And I'll echo your point about the hard work. Certainly, decades of research in cognitive rehabilitation show that the greatest effects are when there's actually work involved in doing this rather than a passive approach. So that's really a key to treatment. And there are a variety of treatments available. There have now been over 80 studies of cognitive rehabilitation approaches, the vast majority of which have shown significant improvements. And there are several systematic reviews. One of the more recent ones showed, using the American Academy of Neurology criteria for therapy trials, showed that, for example, for learning and memory, the modified stir memory technique has been seen as a practice standard. The data is very good, shows medium to large effect sizes, and has been now used in multiple countries at several different languages throughout the world. Practice guidelines have also been found for attention, using attention process training. Attention process training has been used in the brain injury literature for decades and seems to show an effect in have an influence in multiple sclerosis. Another approach is a computerized approach, as Lauren was indicating. REACOM is an approach that actually is utilized in multiple countries as well, is available in a variety of different languages, and the data is fairly good and fairly consistent. So there are a variety of approaches that therapists can use, and the important thing is that these data are fairly good, showing in general moderate effect sizes overall. And they can be used in practice. They are used in our hospital quite frequently. I think the challenge that we've found in our hospital, of course, is the access to insurance coverage. And I think that's an issue that we have to deal with as a group of professionals. Another factor, though, that's really important in understanding cognition and cognitive decline and response to therapy is the concept of cognitive reserve. That is the idea that a lifetime of intellectual activity can form or grow a brain that may be more resistant to the effects of the disease, not to the disease itself, but the consequences of the disease. And there have been now numerous studies looking at this. For example, in the slide here, on the left side, individuals on the x-axis with lower brain atrophy versus higher brain atrophy. on processing speed, you can see at the very low levels of brain atrophy, there's no significant difference in subjects whether they've had high, low, or medium cognitive reserve. But as brain atrophy increases, you can see that individuals with higher cognitive reserve show relative preservation of cognitive processing. However, individuals with low cognitive reserve are shown a rapid and steep decline. At the highest level here, there's a difference of about 2.5 standard deviations. Important point is that all three of these groups have the same degree of atrophy, but the impact of that atrophy is significantly different based on cognitive reserve. So obviously, the environment can have a very significant impact on how the brain responds to the disease. And that would suggest that one, that our therapies are having an effect on the brain itself. And in cognitive rehabilitation literature, there's a quite good amount of data on that. We need more, but there's a good amount of data. But there are also things that we can do in everyday life, and I like to talk about with patients, is that even in everyday life, there can be things that can improve cognitive performance. And so a study recently, it's a very small study, but promising, looking at things that I've actually recommended is take a second language. The idea here is to stimulate your environmental interaction. So this study looked at individuals who took an 8-week second language course. And what they found was that there was significantly increased gray matter volume in language areas of the brain, particularly in the hippocampus and parahippocampal gyrus, and they were significantly correlated with the language aspects of the treatment. So again, the idea here is that I've always talked about with patients is find something that you like, that you perhaps have not been able to do anymore or would like to get back to and let's get involved with that. When you tell patients, we need to do some exercise, and there's some data that exercise can help with cognition, but if you don't want to exercise, you're not going to do it. So find ways that patients would like to increase their sociability and intellectual stimulation. And a study like this is good evidence to help us feel comfortable in that kind of an approach.
Well, thank you, John. This is very exciting news and data, and exciting to see this work, and also, I might take a second language course. So, I think this learning objective number 2 has taught me a lot, and especially around the impact of cognitive dysfunction in MS patients, ways that we can assess it in clinical practice, as Lauren had mentioned, using the SDMT, but now other tools that are evolving, and also potential ways of intervening, including cognitive rehab, but also, as John had mentioned, interventions or really courses like a second language that people can enjoy and maybe use in other contexts. So I think that's very exciting and important news. So let's turn to our final learning objective, which is to evaluate emerging data on the effects of MS therapies on cognition. John, I'll ask you, are there reviews on pharmacological treatments and their impact on cognitive impairment in patients with MS?
Yeah, Tunisia, there are actually a few reviews in this area. In general, the reviews are not showing that there's convincing evidence to support the efficacy of pharmacological approaches to treating cognition in general. That's unfortunate. There are a variety of reasons for this. Primarily the fact that there are methodological issues. For example, in some of the trials that have been done, there's either second or third outcome measure, and therefore the designs of these studies they've not been designed to actually assess cognition. And so that's one of the bigger issues. So as such, currently the data is very limited and not so promising. If you look at one of the more recent systematic reviews, where they broke down the evaluation of the studies in a variety of different ways, primarily by looking at the quality of the evidence. when you look at whether cognition is a primary outcome in disease-modifying therapies, it's very mixed between observational studies and non-randomized trials. But the point is, very few randomized controlled trials have been looked at with disease-modifying therapies and cognition as a primary outcome. When you look at systematic treatment, there's better data here. There's more randomized control trials than there are observational trials. But again, some of these trials have been difficult in terms of the methodological approaches. If you look at the effect size, that's really going to be a key. So the effect size of disease-modifying therapies in general are very low to even negligible. And that's really difficult. That's really a problem, unfortunately. And once again, I think it's primarily because of the fact that the designs of these studies were not meant to look at cognition. Symptomatic treatment shows better effect sizes, but they tend to be not as good quality research studies. And if you look at the proportion of studies, the proportion of positive studies have increased as the quality of the evidence has decreased. So if you look at randomized control trials, about half of them show a negative effect, half of them show positive. So that's not real promising. The observational studies, which again, less quality, tend to show more positive results. But again, the quality is not so great. If you look at the slide here, looking at class 1 through class 4 evidence, class 1 evidence, very few. And there are roughly 5 studies in the literature. You look at class 4 evidence, that's where you see, again, the positive effects. And so it's really quite a challenge, because if the focus is on, if you just focus on studies overall, focusing on lower quality studies may give clinicians a biased impression of the overall literature base. So it's really important to try to look at the quality of the studies and as an important factor. And lastly, I think it's important for clinicians, is that there's an over-reliance on looking at statistical significance. And you can have a very large sample and find significant statistical significance. However, the American Statistical Society clearly states that meaningfulness is really not that important based on p-values, but really the statisticians recommend looking at the effect size and confidence intervals. And to really and I really think that clinicians should stress the effect size in determining whether they can help the one patient in front of them. So I think that the data is mixed and not as positive as I would like to see.
Yeah, you bring up very important points, and I think there is certainly room for growth in terms of understanding the impact of treatments on cognitive impairment, and also really understanding how to interpret these studies with the statistics, as you're alluding to. Lauren, I want to ask you, are there any data suggesting that disease-modifying therapies have a positive effect on cognitive outcomes?
Yeah, there is. I also want to respond to some of the things that John was saying, because I first of all, effect sizes can be considered small, medium, and large, and absolutely most of these studies looking at medication and disease-modifying therapies in particular on cognition, if they show a positive effect, it is a small effect. So why might that be? Well, most of the better designed studies are patients with relapsing remitting MS. And the reality is they don't change much over a 2-year period, right? So the real question is, if you want to look at the effects of disease modifying therapies on cognition, the way to do it is to look, have your 2 groups of different treatments and then look years later, because you're not going to see much on the short term. Nonetheless, there was a recent meta-analysis that did show, taken together all the different studies with disease-modifying therapies, there was a small positive effect on cognition. It makes sense to me that there would be. We know that disease-modifying therapies have a positive effect in preserving brain volume. So it would stand to reason that if you can preserve brain volume, you should be able to preserve cognition. But I don't think you're going to see it over the short term. I think you got to really see it well, you need the time.
And if I could just add to that, Lauren, I appreciate that. In this recent study, the effect size, of course, was small. The nice thing is there's relative consistency, though, in that they're all showing an effect of some sort. And I think if we looked at studies where cognition was a primary outcome, I think that these effect sizes are going to increase. But the data is what it is at this point. And I agree with you by looking at things over time, because if you look at just including all relapsing remitting subjects, just from what we've learned before, half of them are not going to have cognitive impairment. Therefore, they're not even going to change. So they're going to affect your results. So I think we need better design studies for cognition.
Well, absolutely. I think you bring up very important points, and this review and meta-analysis is very helpful. Lauren, I'm wondering, are there any newer studies that have come out since this meta-analysis was published, and what studies are underway that might provide new data to inform our treatment decisions around cognition?
So there have been some exciting new studies. Ozanimod was compared to interferon beta 1A intramuscular, and the result of this study, known as the Sunbeam Study, was that there was a greater percentage of patients who showed improvement on the SDMT in the ozanimod group compared to the interferon group. In the same study, there was also fewer patients on the ozanimod group who showed decline on the SDMT relative to interferon. This finding was present both at 6 months and at 12 months. And it was a small effect, but it was a statistically significant effect. The degree of improvement or decline was determined by the percentage of patients who either had a 4-point improvement or a 4-point worsening. In addition to looking at the SDMT performance, this study examined brain volume in both the whole brain and in substructures. And once again, the ozanimod group compared to the interferon group at 6 and 12 months showed less brain volume loss compared to interferon. This was true for whole brain and thalamic volume. Interestingly, though, because cognition is such a multifactorial concept and function, there wasn't a strict one-to-one relationship between brain volume preservation and SDMT performance, but at least we found both being favorably influenced by the ozanimod treatment relative to the interferon. In addition to the Sunbeam study, there is an extension of the study in which the patients who were originally randomized to interferon after the study was over were crossed over to ozanimod, and the patients who started out with ozanimod continued on the ozanimod. And these patients were evaluated at 12 and 24 months later. And again, the patients who were on ozanimod right from the beginning had a higher proportion, 41%, showing improvement on the SDMT compared to those who started out on interferon and switched over to ozanimod, where only 34% showed improvement. And similarly, a higher proportion of patients who made the switch from interferon to ozanimod showed decline, whereas those starting out on ozanimod and continuing on ozanimod were less likely to show decline. Finally, there's a new study that's been designed and about to start, in which the SDMT is going to be the primary outcome. So this will be patients who are starting on ozanimod, and it will be the SDMT will be looked at over a 3-year period. And change in SDMT is the primary outcome. Secondary outcomes are changes in whole brain and substructure volume, changes in MRI disease activity, patient-reported outcomes, and EDSS, as well as 25-foot time gait, 9-hole peg test, and of course, safety. So I think with all these studies and new information about how the SDMT does with disease-modifying therapy, we've really moved quite a bit forward in our understanding of this problem and how to manage it.
Thank you, Lauren. That's really helpful to hear, and it's really exciting and important that there's new studies showing both an effect on cognitive impairment, as well as well-designed studies which are comprehensive in many of these outcomes. So we've covered a lot today, and I'd like to wrap up by reviewing our SMART goals that you can carry into practice, which are to individualize MS management, balancing treatment efficacy, safety, and patient-specific factors, to continue to educate patients regarding strategies to enhance cognitive function, and to implement routine tools of cognitive changes using the SDMT or other validated tools, and then also to consider referring patients for neuropsychiatric assessment and treatment as needed. I think that's an important tool to keep in mind. John and Lauren, are there any other key takeaways that you'd like to add?
For me, I think I'd like to just leave with a very positive message that I think that we're on the brink of really being able to not only understand and assess cognition better, understand its relationship with brain parameters, we also are on the brink of real treatment. And I think the treatment will start with some form of medication. We'll have to move to some kind of behavioral interventions, likely cognitive rehabilitation. And on the horizon, exercise, I think, is going to be there. We can also today help our patients by getting them engaged and active and build a cognitive reserve. We can actually do that today. So I think the message for me, I think, is a very positive one.
I agree. I think the notion that, patients can do a lot to help themselves, physical exercise, mental exercise, as we've described, being adherent with their disease-modifying therapy, and working with their clinician to monitor how they're doing. And I think the recognition that this is a very important area for people, of all walks of life, including those with MS, that's really critical that we all understand that and be comfortable talking about it and work on it with the people that we see.
Thank you, John and Lauren. This has been a great discussion and really illuminating. And I'd like to thank you, our audience, for joining us. We hope that you will be able to use the information we have shared to change the way that you provide care to your patients with MS in your clinical practice. If any of your colleagues missed today's program, it will be archived at cmeoutfitters.com. I would also encourage you to visit the Multiple Sclerosis Hub on the CME Outfitters website, where you'll find resources for both clinicians and patients. What is the data using DMT on CIS patients? And just to sort of recap, so we've talked a lot about use of disease-modifying therapies in relapsing remitting MS, and there have been several trials in the more distant past which have evaluated treatments in CIS patients. I will note that those studies were done when the MS criteria were focused on prior versions of the McDonald criteria. We now have an updated version of the McDonald criteria, the 2017 criteria, in which most of those patients who were in those early trials would likely have been diagnosed with MS, given the new McDonald criteria. So I think my approach to CIS patients, if I really suspect that this is a patient with early MS, is to watch them very carefully, to repeat MRIs frequently, and to look for dissemination in time, and then to start an MS treatment, and also be sure to rule out other entities. Lauren, do you have any other recommendations in terms of DMT use in CIS patients?
Well, what's happened is that the number of individuals who actually have CIS has shrunk, as you mentioned, with the new criteria. I tend to, if there's a reasonable burden of disease on the MRI, I almost always start with treatment. There are situations, every person is different, but in general, we know that CIS is going to progress, and it's nice to try to avoid that.
Yeah, so I think we agree, and I think, again, just emphasizing the importance of ruling out other entities and also considering the different treatment options. So, John, there's a question that I think is up your alley, and can you comment on tools like DigiCog to assess cognitive impairment in patients with MS? And here the viewer is asking for tools for assessing cognition in psychiatric disorders such as MDD and anxiety in our MS patients.
Yeah, so I'm not very familiar with DigiCog. I do know that it's utilized in trials of Alzheimer's disease. But I think the guidelines that were published by the National Multiple Sclerosis Society in 2018 were fairly clear, and the preference is to use instruments that have been studied fairly well in MS. And so it was, we've mentioned earlier that the SDMT is the primary measure that has been studied over the years. It's the measure primarily recommended by the National MS Society, although the MS Society does say other similar types of instruments could be used. And there are other instruments out there, such as the processing speed test. We heard earlier about BICAMs. So the preference would be to utilize instruments that have been well studied in persons with MS. That would be the recommendation. Regarding some of the psychiatric instruments, again, the National MS Society does have guidelines on this. The recommendations are to utilize the HADS, the Hospital Anxiety and Depression Scale, and or the BDI Beck Depression Inventory Fast Screen. But once again, the strong recommendation is to use the same tests if you do your annual evaluations like Dr. Krupp talked about earlier.
No, thank you. I think that's very helpful information, and viewers can go to the National MS Society website for some of these tests and details. We have another question about a specific patient case, and Lauren, I'll ask you this question. If you have a 32-year-old female patient who's a smoker and has a large number of lesions but minimal symptoms referred to you by their PCP, do you start her on a DMT? And maybe you can comment on sort of the diagnosis potentially in this case and also any treatment recommendations.
So this is just a patient with white matter lesions, no neurological symptoms, who's a smoker. The challenge there is to determine whether this is a patient who actually has radiologically isolated syndrome or not. Many white matter lesions, of course, are not due to MS. A smoker might be someone who has nonspecific lesions. If the patient has migraines, they may have nonspecific lesions. She's a little young to have high blood pressure. So what I would look for there is, first, are the lesions periventricular, juxtacortical, infratentorial? Is there subspinal cord involvement? To determine whether these are lesions that are consistent with multiple sclerosis. In a person who has no neurological symptoms and meets criteria for what we would call radiologically isolated syndrome, there are variable approaches. I would probably follow that patient for a while because their rate of developing a clinical event is not that, it's over a 5-year period. It's not like she's going to develop a clinical event in the next year necessarily. On the other hand, if new lesions develop or if new symptoms develop, then I would definitely begin or consider beginning a disease-modifying therapy.
Yeah, so I think that's very helpful. So another question is, can you give specific examples of which types of patients or scenarios might benefit from each of these approaches, the induction versus escalation approach of treatment that we had discussed? And maybe I'll start to answer this. And I think, a patient who has prognostic factors for either a more highly inflammatory disease course or poor prognostic factors for overall more disability is someone who I would strongly consider for induction therapy. And we've mentioned a number of these different prognostic factors. So number of relapses in the past few years by the time the patient comes to see you. If there's more than 2, I would certainly consider this a potentially highly inflammatory patient. If there's poor recovery from relapses, I would also consider that. Patients who are smokers of non-European descent tend to have a more severe disease course, so I would really consider high efficacy or induction approaches in those cases. Also, the number of prior T2 lesions and the accrual of gadolinium-enhancing lesions, if that was on the higher side and you were frequently seeing new lesions on the MRIs popping up, then I would definitely consider induction. In terms of the escalation approach, this is also a decision to be made with individual patients, and there may be those who have a milder disease course, they've had a very mild relapse, they've recovered fully, and they are looking for something to maintain their disease, but are very worried about the safety or long-term safety data available. And this is a patient that I might employ an escalation approach, but monitor them very carefully for the presence of new lesions by MRI and certainly for any new symptoms, and be ready to switch if they are having new disease activity. So maybe we'll move on to the next question, and it's a question around someone who's interested in switching a patient to an injectable pegylated beta interferon 1A agent. And do you have any experience with switching that you can share? And Lauren, I'll ask you to look at or take that question.
So going from one DMT to another and specifically switching to a pegylated sub-Q injection. In general, it depends on what they are on beforehand, but switching from one DMT to another is not, for me, a big issue unless they're on a medication that has a risk of rebound. There's a risk of having a patient unprotected. So you don't want to stop a medication that has a risk of rebound without making sure that they're on something that's going to offer some protection. So I don't have a washout period. I generally go from one medication directly to another.
Yeah, so that's also my approach too. And I think that probably helps to answer the question. So there's a question about data. What is the data on higher efficacy agents in pediatrics? And we often see issues with medication adherence with the new sub-Q injectable agents being an option. So I'll start by summarizing. In terms of pediatric MS, there is one FDA-approved treatment for that, fingolimod, and this was based on the Paradigm study, which I'm a co-author on. And this compared fingolimod to beta interferon 1A with a very strong effect in the fingolimod group. And so this is an oral agent. There are a number of other agents that are used in pediatric MS, and I think the trend is to use a higher efficacy treatment in this patient group because they do tend to be more inflammatory and have a higher relapse rate than typical adult patients. So that is generally my practice. Around the medication adherence, I agree that that can be challenging, especially in a teenager, and taking sometimes a daily oral pill might be challenging. One approach is really counseling and making sure patients and their families understand the importance of adherence. But also, if that is not an option, then to consider other agents, and this could be either monthly infusions or every 6-month infusions that are available with the B-cell therapies, or the monthly B-cell injectables. Now, all of those are off-label use, so I will mention that. There are clinical trials that are ongoing with some of these infusion or injectable therapies, but all of what I just mentioned is off use except for fingolimod. So, John, there's a question about long-term brain volume data, and why is long-term BVL data needed to correlate with cognitive impairment? And maybe I'll ask you to comment on this.
Well, that's a good question. Long-term brain volume data is actually not needed to correlate with cognitive impairment. And while there is a relationship over time, the relationship tends to be statistically significant, but not necessarily account for the majority of the variance. The majority of it accounts for about 25% of the variance at most. So there's a lot of variability. And the presentation we had mentioned on cognitive reserve, I think, explains this very clearly, where individuals with high cognitive reserve may not show much change over time, but individuals with low cognitive reserve can show a remarkable change in cognition over time, despite similar degree in change in brain volume. So the answer is really doesn't have to, but they do to some degree.
Yeah, no, I think that's very helpful to understand, and I think a marathoner would have little difficulty with a 5K run, but someone who's just starting out might have difficulty, much like the cognitive reserve situation. So, Lauren, question here is SDMT considered the gold standard for cognitive impairment? And if so, can you elaborate why?
It's important to realize the SDMT is a measure of cognitive processing speed. So it's not truly picking up all of cognition. It's just picking up your speed of processing. It's very useful as a marker of cognitive change. For example, both in the pediatric and in the adult MS groups, measures of cognitive processing speed, like with the SDMT, correlate very well with broader neuropsychological batteries. So it is indeed the gold standard for assessing or screening cognition in MS. I want to just caution, I use it in my practice, but it will tend to jump around a little bit. So you have to make sure that patients are really paying attention and trying their best when you administer it.
Yeah, no, I think that's very helpful to understand. And here's a question for John. It's sort of around the DMT effects on cognition, and the writer asks, are you surprised that DMTs do not have a salutary effect on cognition, although we've seen some data that ozanimod does? So can you comment on this?
No, I'm not surprised given the nature of the clinical trials. I think you have to look at the studies and read them carefully. If most of the studies, and they are by far, having cognition as a secondary or tertiary outcome, and they were not designed to include, for example, patients who have cognitive impairment, it doesn't surprise me. I think what we've said earlier is what's needed are clear clinical trials with primary outcome being cognition. The one or two trials that are out there, the effect sizes are larger. So it doesn't surprise me, but I think it's important from a clinical perspective to take into account that the data right now aren't that strong. So it's not a surprising thing, and we just need better data.
I agree, and I think a question related to this, are there any data on biomarkers and progression of disease response and or cognition? So there's a lot in here, and I'm going to start by just commenting on biomarkers of progression of disease, and this is an area that's in evolution in terms of biomarkers that I think of. I think about clinical features of a patient, and would that predict or associate with a more severe disease course, or a patient who is more likely to develop progressive MS. And we've talked about those during the session, including older age, poor recovery from relapses, high MRI T2 lesion burden and also visible brain atrophy are things that we can immediately assess. And then also there are evolving biomarkers in terms of blood-based biomarkers. There's certainly a lot of data on neurofilament light chain and other blood markers. I think we're still waiting for the final test to become available and understand the tangibility of that. But certainly there's a lot of data in evolution. The same in terms of disease response or treatment response. And I think one important point to take away is that it's important to continue to monitor patients who've been started on a disease-modifying therapy frequently, both clinically and I think with MRI to assess for new disease burden and new lesion formation. And Lauren, I'll ask you to comment on, are there any sort of biomarkers of cognition that you use in your clinical practice?
What I tend to use is two things. One is cognitive processing speed, the SDMT, and the other is I do look at brain volume change. Now that's very hard to look at in a clinical situation because people go on different scanners, but there are increasingly software programs that are improving and more will become available that can be a reliable indicator of brain volume. And when I see continued brain volume loss, I'm concerned, and I use that information in terms of not only recommending exercising, but in the stimulations that John recommended, but also I think what DMT is the patient on.
Yeah, and I think that segues nicely into another question for John. And is there evidence of additive effects of cognitive rehab with exercise and pharmacotherapy? And what is sort of the cocktail or plan that you recommend for patients who are experiencing cognitive dysfunction?
Yeah, there's not a lot of data on additive effects. There is a very good clinical trial ongoing right now, actually looking at cognitive rehab plus exercise versus those independently, and hopefully in a year or two we'll have that data. But I think from a clinical perspective, I think it's important to recognize what Dr. Krupp mentioned. Early on, if you see cognitive impairment early on and gray matter volume loss early on, that should be a trigger to monitor your patients. There you might want to consider a DMT that shows some potential effect if you have that choice. Once the degree of cognitive impairment becomes to the level where it's really affecting the person, you really have to do cognitive rehab, because cognitive rehab is going to address the individual person, not the broad kind of treatment you might give with the medication. Exercise data is promising. It probably can't hurt as long as it's monitored, but I think that ultimately those three approaches will be the approach to cognition in MS.
Well, thank you, John and Lauren. This has been a really wonderful discussion, and I'd like to thank the sponsors of this session, Bristol Myers Squibb, and also to our CME presenters. So thank you again, and I wish you all a very good ACTRIMS meeting.
Thank you.
Goodbye all. Thank you.